Hi, everybody. Welcome to Pelvic Health Explorers membership. This is the June interview with the amazing Dr. Julie Barron. We are so excited to be here today with you. Julie was referred to me for the interviews through Kathy Wallace, and of course, you all have seen her interview on prolapse, and she'll be back in August or September talking about the back end of prolapse, the rectal prolapse. But Julie is working in and around and is one of those specialists in pelvic venous disorders. She's the pelvic health therapist, and I would like Julie to introduce you to the group. Tell us about your journey, your professional journey, and how you got here.
Sure. So I started my career 15 years ago in sports and orthopedics, and I was really happy there. And then I got pregnant, and I had a really rough time finding good care to help me manage that. So my first pregnancy, I had this sudden onset of preeclampsia. They didn't know why. It was really emergent, and then my hypertension persisted into postpartum. And in retrospect, it was probably because I had pelvic venous disorders, but nobody was talking about it then. And then I went into my second pregnancy naively thinking, okay, I'm going to crush this pregnancy, like I'm going to somehow control the variables differently, which is clearly impossible. And 4 months in, I ended up separating my pubic symphysis, and it was brutal. And I would love to say that it was because I was doing something really noble, but the reality was I was racing my husband up multiple flights of stairs. We were competing for a free spa service, and there was only one free coupon per family. And so we just looked at each other and took off up the stairs, and you had to get there in a certain amount of time. And when I got up the fourth flight, I just heard this huge pop and couldn't move. And
Mm,
like the good news is that it like forced me to go into pelvic floor PT for myself. The bad news is it took me going through four kind of negative pelvic PT experiences to find, one that worked. And I was kind of my eyes were, opened when I started working with Kathy Wallace as my PT, not knowing who she was at the time.
mhm.
Um, and just this bulb kind of went off, and I started pursuing more continuing education in prenatal postpartum care, and then started really pivoting more into this niche. And then 2 years ago, I actually opened up a practice with a group called MTI Physical Therapy, and it's an out of network private practice specializing in pelvic health. And I'm the director there and having a great time just kind of helping this really special patient population. But I definitely credit Kathy to kind of turning me onto this niche. And it was funny because my friend, who's a pelvic PT, she was talking to me about a year after I graduated, and she was like, who did you end up seeing? You had such a hard time finding care. And I was like, oh, I found this person named Kathy Wallace. And she was like, what? That's like having Adele as your voice coach. And you had no idea. So it was like having Adele as my, you know,
Mhm.
voice coach, but Kathy.
She's
Um,
definitely an icon in our field. We are so
she
grateful to have her around. Absolutely.
certainly is. So that's how I got into pelvic health. But my journey into kind of falling in love with teaching others about pelvic venous disorders that came a little bit later.
I love your story and thank you for sharing it because I think a lot of us think that I'm a pelvic health physical therapist. I'm not going to have problems in pregnancy. I know everything to like take care of and do, but yes, we can't control the uncontrollables and all the variables. And I think your story is so vulnerable and so telling. Um, Tell me a little bit about, I just want to dive in and I'm going to take the first segue that I heard. Your preeclampsia, hypertensive effects and having that into postpartum and how you have kind of looked back and thought, wow, I probably had some pelvic venous disorder issue going on. Tell us about that connection there first, because that's the first one I heard here.
Yeah. So I wasn't showing very clear signs and symptoms of PVD in that first pregnancy. So pregnancy is one of the biggest risk factors in
Mhm.
developing PVD in the first place. But I did have this pre-existing compression of my renal vein. And no one, I mean, I had never had imaging. I had no idea that this existed. But the combination of this full compression of my renal vein up by my kidney, and then the insane demands that pregnancy places on your hemodynamics, right? Your gonadal veins, for instance.
Mhm.
I think it really, in retrospect, taxed my body to this extreme level. And the doctors, they really had no idea what was going on. They thought maybe I threw a clot or something, but it literally was only in the last couple of years that we kind of looked back, and I was working with my gynecologist, and she was like, we were just like, this must have been the start of that PVD kind of showing up for me. And we all kind of missed it. But
Mhm.
my signs and symptoms really started probably 2 years postpartum with my second.
And what kinds of signs and symptoms did you have?
So um it kind of started with this insidious onset of this pelvic floor ache. It was just this heaviness in my perineum and my pelvic floor, and I would feel it when I went hiking. So I would be, 5 miles, you know, into a hike, and I would just be like, this isn't fatigue. It's just this heaviness. Like it felt like something was kind of like falling out. But then
Mhm.
I would look when I got home and, it wasn't anything. And so it just started escalating. And so it started showing up 2 years postpartum. And then over the next 2 years, it started happening earlier. So I would be trying to cook dinner at the end of the day and I wouldn't be able to stand. It would be 7, 8 out of 10 pain. And then I would go to sleep and wake up and it would be gone. So I'd be like, okay, maybe this is, maybe I'm imagining things, you rationalize things, you're in that season. Then I started getting urinary urgency. And when I went back to some of my doctors, they were like, maybe this is like a mild prolapse because you've got this heaviness, this pressure, and this urinary urgency that seems to track. But when they tried to give me a pessary, it felt awful because there was so much venous pressure proximally pushing down into my pelvis that there was no space for
Mhm.
a pessary in there, right? But externally, I looked fine. Um, then it started progressing. COVID kind of hit, and I was doing a lot of sitting, doing telehealth, homeschooling my kids. And it started getting to a point where I couldn't sit for 30 minutes without that same pain that had started, with hiking years earlier. And then finally it progressed into pain post intercourse. And in this process, I was seeing every specialist. I was driving myself crazy because I work with people with chronic pelvic pain and I couldn't figure this out.
Mhm.
Um, so I saw gynecologists, colorectal doctors, GI doctors. I was having all this bloating. I almost looked like I was like at the end of a first trimester, right? And everyone's like, you're fine. I think this is just postpartum. This is just what postpartum will look like for you. And which is totally unacceptable and sad if that were the case. And they said, a lot of people improve once they get to menopause. And I was like mid 30s, and my mom went through menopause at 52. So clearly I had to do something.
Mhm. What a bad story. Oh, well,
Yeah.
postpartum, this is at this point, you're like almost 4 years postpartum,
Yeah.
right? 4 or
Yeah.
5 years postpartum, and
Hmm.
that it'll get better when you get to menopause. It's like, it'll get better if you get pregnant, it'll get better if. It's like, what you're basically saying is you don't know.
Yeah, exactly.
Not you, but the providers just didn't know, and so then they just,
Yeah.
like, do that tip it off thing where, "Oh, just wait a few years, it'll get better," like,
Yeah. And
no.
honestly, they were great providers. I think it's just
Mhm,
they didn't know any better. None of us
mhm,
did. And you don't, you can't do better unless you know this pathophysiology and how it presents. And unfortunately, it's not something that people are taught in school.
mhm. So how did you navigate this? You got through these providers, they all told you to just wait about
Yeah.
10 years and, maybe it would get better.
Yeah, exactly. Well, at that point, I felt like a desperate woman, and I poured myself into research, all the literature I could find. I literally went back to 1800s and came all the way up through the present. And I started noticing these parallels with these venous disorders they were talking about, and they used different language way back when they were talking about pelvic congestion syndrome and things like that. And it really started to resonate. And I began to realize that I needed to start pursuing specific imaging to get a diagnosis. And I needed to find a vascular surgeon. And as I'm like coming up with this plan for myself, I stumbled into this GFAM webinar, and it was Tracy interviewing a surgeon named Dr. Brooke Spencer. And she
Mhm.
is this epic interventional radiologist in Denver, Colorado. And the title of the course was Venous Disorders of the Pelvis. And I had just come out of a conversation with one of my doctors, and I'd asked them, are there venous issues that could be causing this in me? And they confidently were like, no, definitely not. And so it was like a mind game, it felt like. And so when I saw this webinar, I kind of went into it, and 10 minutes in, I just burst into tears because I had never heard a provider talk about my experience in this way. And she was saying, yes, this is a thing. Yes, this is how you diagnose it. There are treatments for you. You do not have to live this way. And I kind of put this plan into place, found a vascular surgeon who was in the next town over and specializes in this, which is actually quite rare. So I felt like the stars were aligning for me. And I ended up pursuing a gonadal vein embolization and sclerotherapy. And when I came out of this minimally invasive outpatient procedure, I kind of came out of that haze. I just had this moment of clarity where I was like, I have to tell everybody about this. Like, nobody knows that this exists and that you can do something about it. And I'm here now talking about it. So
That's great. And I think part of the thing is that I think people are somewhat aware because I know there's chatter around, but they're not aware of like who to see, what they
exactly.
can really do about it. And from a pelvic health standpoint, I think most of the chatter that has always gone around in the last, at least in the last, I think even more than that for me was we always, whenever we had a suspicion of this, we sent, we had people in the place where I was working in Pittsburgh that did a lot of lymphatic work.
Mhm.
And so those were always kind of like referred to the pelvic health therapist that does the lymphatic work as well,
Mhm.
with varying degrees of results, but nobody really to like really look at this and look at the imaging. And I remember when some of that specific imaging started to come out that it was like, oh, how do we get people in for that? How do
Yeah.
we do this? So tell me how you, like, what imaging, what is it that, well, first of all, let's go back for a second because you
Okay.
listed off some amazing symptoms that I was thinking that's just sounding exactly like prolapse. How are we going to tell the difference between, this, like that heaviness and the
Mhm.
urinary urgency, and that it's kind of getting worse? As we all know that, urgency always kind of takes that form and gets a bit worse until it's actually treated. Um,
Yeah.
did and just another question from my point of view, during the time of COVID, did you actually have COVID and did that change your symptoms at all or make them worse? Or did none just line up that way?
It didn't line up with COVID. I ended up getting COVID after the fact. I think it was probably 2 months before my procedure, but it didn't, I mean, I was in such bad shape at that point. My pain was 9 out of 10 most of the day. And that was consistent with COVID. It wasn't exacerbated by it. But I
Okay.
think it's interesting because we're clearly starting to see, you know, with long COVID and other diagnoses like this exacerbation. But that wasn't for me, the
Yeah.
experience.
And I think that's something that we need to kind of pay attention to with the long haul COVID, presentation is that, neural sensitivity is high with
Yeah.
that and can really maybe even mask some of the other symptoms that could be leading people to pelvic, venous disorders.
Mhm.
What you said there was some bloating too. What other symptoms should
Yeah.
we be watching out for? Like, help us paint that picture just a little bit better so people can start to
Yeah.
say, this isn't like the normal chronic. Well, is there ever normal chronic pelvic pain? But this is not fit.
Different.
Yeah, this is looking some, I think we all know that something's different or not, but what is it? Like, can you talk us
Okay.
through some of those symptoms? That'd
So
be great.
Well, let's go walk it back a little bit further. So
Mhm.
pelvic venous disorders, they're abbreviated PEVD. So everyone loves a good acronym. There's already one that exists for PVD. So we need PEVD. So PVD is this wide spectrum of abdominal, pelvic, and leg symptoms. And they occur as a result of venous obstruction, venous reflux, or a combination of both. And these venous abnormalities can happen in 4 regions of the body. And I think people kind of assume that, oh, maybe it's just isolated to like the uterus or gonadal veins, but really you want to have these 4 regions of the body evaluated. So I'm just going to share my screen for a second
Yeah, thank you.
um, and show you a little picture. So these are the 4 areas that we need to consider whenever you want to rule in or rule out PVD. Now, you could do that with just a basic transabdominal duplex ultrasound. So most people, when they go in to get this workup started for chronic pelvic pain, they're given a basic ultrasound, but they are not looking at their veins. So we want to look at the renal vein and the iliac vein. They're in this darker blue color. Those are the 2 areas where you can have venous obstruction. If you go to the gonadal veins and the internal iliac vein, those are in teal. Those are the regions where you can have venous reflux. Now, a person's symptoms are going to be really variable and individualized based on what regions are involved. So you could have all 4 regions involved, and your symptom could just be left labial itching. And then you could have maybe 1 region involved and you have symptoms like me, like they're debilitating. It's this ache and heaviness and really limited function. So it kind of covers this whole wide spectrum. So there is a classic presentation of symptoms, but there's so much that exists out of that. And I think we are in such a unique position to sort of capture these like breadcrumbs and kind of put them together. So some of the classic clinical findings are going to be here. So there's going to be this chronic pelvic pain, but the key is that it's going to be non-cyclical. So a lot of people will say, well, my pain comes with my period. Now, this is not that. There is always some degree of something in the background, kind of some little rumbling, but maybe it's so small that you just rationalize it and you're distracted and you're in this busy season of life. So you kind of don't notice it until your period comes, right? So it's always there to some extent.
Mhm.
Now, pregnancy is the biggest risk factor for developing this. So this classic presentation will be seen in this pre-menopausal grouping, so 25 to 40. Oftentimes they have lower BMI and higher birth weight babies, but that's not always the case. Now, this is interesting because research always focused on this patient population, this age group, but now people are realizing that it actually can be present in postmenopausal people too. They can come with pelvic and vulvar varices, or this can show up in people who are 16, 17, 18. But if we get so fixated on this one classic kind of snapshot of PVD and how it might present, we're going to miss all of these other groups of people who really would benefit from care also. And that's only been kind of like recently in research that's coming out.
Mhm.
Um, there's also, again, that classic pelvic floor heaviness and ache. And this with venous pain is very particular. So it worsens with dependent positions, standing, sitting, exercise. You have this increased blood flow to your pelvis and legs during those times. So that's when people are going to get more symptomatic. And again, non-cyclical. We talked about urinary urgency a little bit, which it happens because internally you can develop these varicosities that sort of push in and encroach on these perivesical spaces around the bladder. So when that happens, it creates dysuria and irritation and urgency. And then when you treat the PVD, that just goes away, which is pretty cool. And that's what happened for me too. There's dysmenorrhea. One of the most classic symptoms of venous pain is a postcoital ache. So This, again, with intercourse, you have this increased blood flow to the genitals, but this ache shows up for maybe 30 minutes after the fact, maybe an hour, but in some people it could last 3 days and they are like in the fetal position, doubled over. It just kind of varies. But when they mention this, well, like I have these symptoms after sex, not during sex, that's like a big flag to kind of listen for. More research is coming out saying sometimes this ache happens with increased arousal. We're seeing this more in people with PGAD. And then another study just came out saying like it's worse with deep thrusting. But with chronic pelvic pain, we're kind of thinking dyspareunia, right? And this
Right.
is more specific than that
Mm.
when veins are involved. And then finally, extra pelvic varicosities. So 20 to 40% of people with this who are assigned female at birth will have these vulvar varicosities. And if they're pregnant, it's a little bit different because sometimes you have this, and then as soon as you're postpartum, hemodynamics kind of stabilize and everything's fine. But if they show up once in, say, like a first pregnancy, they're definitely more likely to progress into any subsequent pregnancy. So you want patients to know about this. And if you're working with pregnant and postpartum people, this is definitely, it needs to be part of your differential diagnosis. And then in someone assigned male at birth, this could present as a left varicocele. So these are like the classic signs and symptoms. You could have a few of these, you could have all of these. And then to make it more complicated, you could have any of these.
Mm-hmm.
So it's so special and unique depending on the person. But because there's like this GI involvement, because there's this bladder involvement, migraines, it's kind of all over the map. So when you start recognizing this in people, you just start noticing those patterns. But there's this new study that came out and it's kind of showing this new trifecta. It's EDS, POTS, and iliac vein compression. So people with POTS have a higher rate of iliac vein compression. And when you treat the compression, their POTS symptoms improve. So if someone comes in and they're like, yeah, going through their medical history, I've got POTS, like I'm a little hypermobile. And then you notice these other signs and symptoms, it's just something to have on your radar.
That's very, very interesting. And I had a client recently, about a year or so ago, who was, who actually her presentation that started was the POTS presentation
Mm,
that led her and I down to like into what was going on with her pelvis. And then, discussing that, have you thought about imaging? And sure enough, she had the vein compression.
that's
And
amazing.
yeah, and so through that, she was able to, like, start getting the care that she really needed. The
Mhm.
pot stuff is still there. It's improved, of course,
Of course.
but, it kind of is it's like you say, it doesn't always tick the boxes, but it's almost like we have to be aware that something else is going on.
Mhm.
Something else
Yeah.
is going on, which is where I think the imaging comes in so well. Tell us
Mhm.
about that. What does that look like? What do people ask for? What do they
So
need to advocate for?
I don't think that people know what to ask for. And I think as pelvic PTs, we're in this really awesome position to help advocate, right? And
Mhm,
sort of facilitate this process. So when you have chronic pelvic pain, your general workup is this basic abdominal ultrasound. Doesn't look at any veins. From there, people are usually, they do labs. And then 40% of people with chronic pelvic pain pursue diagnostic laparoscopic procedures because they're desperate.
mhm,
This procedure in particular is really problematic with PVD because it misses 80 to 90% of cases
mm, mhm,
because the person's put in a Trendelenburg position, they're filled with CO2, so any dilated veins that are there are hidden. And so
mhm,
that's devastating. You come out and they're like, we didn't find anything. And then a lot of people, as a last resort, they're like, well, maybe I guess I need a hysterectomy or that's recommended. And I see it all the time. It's devastating. People who are family planning in their early 30s and now they're told like, I guess we'll do a hysterectomy. And unfortunately, when you do that, maybe you have resolved venous reflux in any parauterine veins, right? But they were just the victim of something else. So none of those other four regions of the body, those four venous spaces, none of them were considered in that treatment. And so oftentimes their pain is not resolved. So a very accessible, insurance approved option is a transabdominal duplex ultrasound, where they can look at all four of those regions in supine, side lying, and standing, and kind of get a sense as to what's going on. But the only caveat is you have to have a vascular technician who knows how to do this performing the test. So they need a little bit extra in terms of like classwork or schooling for this. And you're usually going to find them in a vascular clinic. But if you send a patient out and you even tell them, ask for this, or get your primary doctor to refer you and write transabdominal duplex ultrasound. If they come back to you and it's just like in the write-up, well, some dilated parauterine veins, pelvic congestion, that's not enough.
Mhm.
So that wasn't the right fit. So you have to kind of do your due diligence to find a clinic that does this work, because it makes a huge difference.
And
And
we'll
then,
look at all 4 regions, right?
yeah, yeah.
Yeah,
So
okay.
again, the thing is that if you pick the wrong diagnostic imaging, you guide your treatment off of the imaging. So you then run the risk of choosing the wrong treatment, and
Mm.
then the person's outcomes are going to be negatively affected. So transabdominal duplex ultrasound is the place to start. And then if they find anything abnormal, they would suggest something like a venography study. So they can do dynamic imaging in this way and really get a sense as to the degree of venous involvement. So sometimes an ultrasound will say, yeah, there's actually compression here. And then you do the venogram and you realize it's actually not worth treating that. It's worth treating the reflux further up the chain. So it just gives you all of the data you need to make a really informed decision about your treatment, because we want to be as minimally invasive as possible.
So first thing is get all 4 regions
Hmm.
the right look, and from there, base your treatment on what the venogram shows because
Yeah.
that region may be involved, but it could be something else that is causing it.
Yeah.
So, it just gives people a reason to go look further and more completely, along that line. This is reminding me so much of endo, as far
Hmm.
as, like, they only looked for endo in one place, and therefore they only found it in one place, and they never looked
Exactly.
anywhere else, ever.
Exactly.
Ever. And they only did ultrasounds of the uterus in one position in one direction, and they never looked,
Mhm.
with the at the, area where it was most vulnerable in the in the retrouterine, region. And then so then they like with this, it was like, okay, well, we found a little stuff here, so we'll do this, and then but it didn't correct the problem because they didn't look at the whole
Yeah.
scope.
Yeah, and that's why I think syndrome language is really limiting, because if we use words like pelvic congestion syndrome, that's kind of talking about the uterus, the parauterine veins. There's clearly some sort of congestion, some reflux, but that is a symptom of something larger. That's not a diagnosis. That's just data. And I think when we use this language, it's very like short-sighted. And for a lot of people, when they're told they have pelvic congestion syndrome, that's kind of like just a dead end. Like I've had
Mhm,
patients where they didn't respond to traditional pelvic PT, and their pelvic PT was like, well, I think you might have pelvic congestion syndrome, but like you're discharged because there's
mhm.
nothing more we can do. So that kind of language again is really limiting as well, influences diagnostic test selection, treatment options, and then outcomes. So yeah, it's a symptom of something larger for sure.
Yeah, this is great information. And so Venus centers are the places to go for this and looking for the technicians that really know how to do this proper. And we'll look at all 4 regions that
Mhm.
you described in your slides that you
Yeah,
showed so that they're looking at the all the renal veins and the iliac veins and
everything
those
else. Yeah.
areas to make sure that we're getting everything. How many of your clients have resorted to using abdominal binders, compression socks, different things, compression underwear and do they help?
So compression has
Or
been
do they
used
make it
for,
worse? Like, that's really my question is like,
it
should they even
depends.
do this? Yeah.
It depends on the person. So a patient's pain presentation is dictated by how their body has compensated for venous pressure buildup in the system. So, for instance, if someone had compression at their renal vein, their body can either just choose to kind of keep that pressure there, and then your symptoms are going to be more like left flank pain, maybe some blood in the urine. So, that's your body hasn't compensated in that scenario. But if your body's like, I don't like this, I want to push this down, I want to move it distally in the chain and get some relief, it's going to start turning to your gonadal veins. And then your gonadal veins start overworking and they're kind of getting more and more dilated over time, refluxing. So the blood's not moving back to the heart very easily. So at that point, your body could compensate even more and just keep pushing it distally in the chain into the pelvic floor and out what's called pelvic escape points. So your presentation is going to be really, really different overall. So let me see. Hold on. I'm going to show you another picture. So pelvic escape points are interesting because we talked about vulvar varicosities.
Right.
Sometimes it's not that obvious. Sometimes it's one of these spaces and it's not like this clear, visible, bulging vein. It's just a little bit of distension. So maybe by this P point, this is a great spot. This is the perineal region. It covers like inner thigh and posterior labial varicose veins. So sometimes you're just going to you're going to palpate around, you're going to do your external exam, and you'll find that these areas are really firm. They're sore, they're firm to touch. It almost looks like if you were going to have them kind of try to lengthen out, bear down a little bit, they're already there. It's like they're already so distended that these tissues are kind of just, there's nowhere for them to go. So sometimes that's how they're going to present. You could have eye point issues. So that's going to kind of lead to those labial varicose veins or varicocele in someone assigned male at birth. And if you look from this view, again, you're going to get all this distension. Sometimes you start losing these nice anatomical markers. You don't get this clear delineation between structures anymore because, again, it's just so much pressure. So if they've compensated in this way, maybe they're not going to have that chronic abdominal pain. So they could wear something that compress their abdomen a little bit more. But if they haven't compensated this far down the chain, you are right. Pressure on that abdomen is going to feel bad. So your compression options are going to be a little bit different. So maybe you use, so there's this brand called Underworks. They've got this really nice prolapse. It's called like the prolapse boy short or something like that. Do not get the briefs. They're really awkward in how they're cut. It's the shorts that are great. So what it does is it has this drawstring, or when you pull it, it lifts the whole perineum up. It's like having one of those jock strap options, but the surface area is larger. So there's no compression elsewhere. The band hits below your belly button. So if you don't like that abdominal pressure because your symptoms are more kind of proximal, you've got that bloating, that kind of thing, this is a great choice. The perineal support is also great if you do have, those vulvar varices, you feel that heaviness, you just need to feel like someone's like holding you up. A lot of people are like, I walk around with my hand right here, just supporting myself. So that short is a great option. But if you can tolerate a little bit of pressure on your abdomen, there is a group called Juzo compression. And they've got, it's about 15 to 20 millimeters of mercury of compression, which is more than the Underworks short. But some people love this. It makes them feel amazing. They exercise in it, feels great. You get this reduction in venous reflux, and then you also get this like massaging of the muscles to help kind of pump things back up toward the heart. And then if you can tolerate a little bit more, research shows that if you can get closer to that 30 to 40 millimeters of mercury, you're going to get good reduction of venous diameter and standing. The only problem is like it's really uncomfortable. So there's a happy medium with a Mojo compression short. Those are 20 to 30 millimeters of mercury. And again, they're kind of like the Juzo short. You could wear them, especially if you can tolerate the abdominal pressure. wear them under dresses, wear them to work out, whatever. But um, there's lots of options. So in our office, we have so many samples. And then when we're talking about compression on that very first day with patients, they try them because it's disappointing when you pay like $60 for a pair of shorts, they come to your house and it's like the wrong size or it feels bad. So
Mhm.
to kind of eliminate that step for them, we just have them try it all on in office. But compression's great. It's been around for thousands of years for a reason. And
Mhm.
it does make a difference, but it is a piece of the puzzle.
Right, right. The reason I was asking about if there was some danger to it or red flags to it is because, we think about people with congestive heart failure
Mm,
that you definitely don't want to do anything to bring the fluid back up into the pulmonary system, right?
mhm.
So oftentimes it's like you can't wrap somebody's legs or give them compression socks until they have had a conversation with their cardiovascular
Yeah, yeah,
physician because, the last thing we wanna do is, like, overload the pulmonary
yeah,
system. I didn't know,
exactly.
when you were talking about reflux within especially in and around the renal veins, um, I wanted to be sure that, do you check hypertension with people with this? Because, when we think about renal veins, the first thing that comes to my mind is hypertension. You know,
Yeah,
like, is that or excessive urinary urgency because the, hormones around when we have
mhm,
when the renal veins are, compromised, it increases the hormone that makes us feel like our body is under compression, and so we pee more,
mhm.
kind of like when you go swimming and you get out of the pool, you gotta, like, run
Yeah,
to the bathroom and you could,
yeah,
the urination takes forever. It's like, "My goodness gracious, what the heck," right? So,
um,
I didn't know
y
if it would I guess you just watch do those symptoms get worse, then you remove the compression. I'm just kind of
yeah,
doing the thought process here.
yeah, so I haven't had anyone feel worse. That's a lie. Not because of hypertension, but just because they just didn't like the sensation of something on their skin. They were just
Yeah.
so hypersensitive at this point
Mhm,
that it just all felt bad. But there are plenty of people who feel like the compression gives them an opportunity to work on their venous return and this pumping with muscles, contracting and relaxing through exercise. And the only way they can do it is to wear the compression to kind of, tolerate that outlet, that
mhm.
movement outlet. But I haven't found that it makes anyone worse in that example that you gave. Um, there was a study in 2017, and they looked at compression shorts and stockings in people and how it affected their symptoms. And they found that the stockings really had no impact on symptoms of PVD, but they found that class 2 compression shorts, so this 30 to 40 millimeters of mercury, that reduced dyspareunia and overall discomfort in over 80% of the people. But again, a lot of people can't tolerate that pressure. And
Right.
maybe you can tolerate it in standing, but then you sit in your car and people are like, this feels terrible. So I think empowering people to have a couple different compression options is really great because you don't need a ton if you're just watching Netflix, but maybe you do if you're going to go play pickleball or, whatever it
Mhm.
is. But compression
Right.
is a great tool. So that's like the first thing, that first visit with people, really trying to kind of educate them on those options.
Yeah, that's amazing, and it's such easy things for people to access and to start working with and playing around and getting some sort of relief with. What do you use for postcoital? Do you recommend the lighter compressions since people think about sex in bed and then going to sleep? I mean,
Yeah, so
we're
I
talking
don't,
about busy people with little children. If we're looking at the
yes.
postpartum population, there's
So,
it's not the
so
option of the people who don't have kids and they can do it anywhere.
Mhm. Yeah, so post intercourse, a lot of times I will have people put themselves into restorative inverted positions because I don't want anyone to fall asleep wearing a ton of compression. That's not
Right.
necessarily
Exactly.
great,
Mhm.
right? But if they can, you know, get ready for bed, whatever they're doing, or maybe they're not having intercourse at night, maybe it's in the morning. But if they can take a yoga block, put it under their pelvis, get their legs up on the wall, and they can just hang out there for 10 or 15 minutes, oftentimes that really takes the edge off. It gets everything to kind of come back to the heart. And then they feel like they, you know, have more pain-free time after the fact.
Mhm. Yes, great advice, easy to do.
Yeah.
And, even if they just, like, did it, on their bed, just turn around, put their feet up
Yeah.
on the bed frame
Yeah.
and stick the a couple of pillows under their pelvis,
And
good to go.
again, like
Uh-huh.
people are, like people without this are like, well, that's kind of annoying, right? But people with this are like, yes, because this
Do
saves me
it.
from, 3 hours to 2 or 3 days worth of pain, which takes all the fun out of intercourse, right?
Right,
So
right,
if
yeah,
they
you
have
start
a
hating it when you start thinking that the consequences of me having a good time right now or having
Mhm.
this intimate, um, peace that comes along with relationships, they start, dreading it, and then, as we know what we know about the brain, um, there's gonna be hypersensitivity and overprotected that's gonna start happening because that protective side of the brain is gonna start saying, "No, no, if you
Yeah.
do this, we're gonna make you have pain right away so you don't even do it." Right, right. So that we've got, a whole complex of things that, we're working with people on to try to, make some changes here for them.
Yeah.
How so they can go ahead and start playing with compression
Mhm.
while they're getting into and getting the right, ultrasound, the transabdominal duplex ultrasound for all 4 regions by a center
Mhm.
that knows how to do it.
Yes.
Um, do you see them a lot before they even get this? I mean, these are great things for people when we're kind of like wondering what it is and if this gives them relief and can this help? They get the right types of things and they maybe need a procedure that's either going to de-obstruct or go up the chain and figure out what's going on from the venogram. And then you see them after. Like, tell us what else we as pelvic health therapists can do to support these people. I'm
Yeah.
thinking, this pre stuff we just talked about is good. I'm
Mhm.
sure the compression works post too.
Yes, absolutely. It's needed post.
But what other things like we get that
Oh,
diaphragm going? I'm sure breath
yes.
has something really
Yes.
important to do with this because of
I was
helping
listening
things
to
move and
I was listening to one of your podcasts and you were talking about like the rib cage and the diaphragm and I was like, yes, this is exactly what I'm talking about. So traditionally pelvic PT focuses on the abdomen and pelvis.
Mhm,
And when you apply that traditional approach to PVD, it's not going to do much because treatments like visceral mobilizations or internal work, it's people are going to get exacerbated by that approach. I've had so many patients come and they're like, they work on my abdomen at my other pelvic PT and they do a lot of like release of OI and stuff. And then they're just in so much pain. So I think if we can zoom out and recognize that the pelvis doesn't exist in a vacuum, we can treat it indirectly by just looking at other parts of the system. So a key part of really impacting their quality of life is finding ways to maximize their venous return through positions and different exercises. So there are, let's say, 4 things that I work on with people, and I'm typically seeing them once a week um, until they get like a good grasp on things. Then they go into their procedure, and then they come out, and we kind of peel back some of the other compensatory layers that are still there, even
mhm,
after the anatomical abnormality is fixed. So first, we work on getting a zone of apposition. So it's this area of attachment between the diaphragm and the rib cage, and it's one of the most important aspects of breathing. So in order to have this, we need to be able to take our rib cage. When we inhale, we kind of distal ribs are more externally rotated, right? But to get a
mhm,
ZOA, you need to be able to internally rotate and adduct this rib cage to get the diaphragm to restore its position in the rib cage in this like nice domed shape. Now, most people with PVD, they're not exhaling. They're in this constant, hypervigilant, hyperinflated state. They don't know how to exhale and get into their
mhm,
parasympathetic nervous system, which exacerbates their pain more.
right,
So this zone of apposition we work on by teaching them how to exhale, get this adduction, internal rotation of their ribs, learn how to use eccentric IOs and TAs to kind of hold that position so that in their next breath in, they're getting nice rib cage expansion, that diaphragm is like actually ascending all the way up. That's like step one. Yeah. So I check this across visits. I utilize strategies from and paradigms from Postural Restoration Institute. Have you ever taken any of their classes?
I've seen their work.
Okay. So
Hmm.
they talk about ZOA a lot. So that's kind of where that comes from for me. And then secondly, we need a rib cage that expands in 360 degrees. So I think traditionally belly breathing has been really emphasized in people. And when you actually break down the mechanics of breathing, you need to have chest expansion. The lungs are filling. We need movement here too. Belly breathing is going to very much bother patients with PVD because it's just putting more pressure down,
Hmm.
right? So if we can get them to find that ZOA and then expand into the back of their rib cage, I mean, it's a beautiful thing. It really keeps their diaphragm a lot happier. You can move through this whole path of excursion. And that alone, once they start getting the hang of that, like they feel the difference in their body like very quickly.
Hmm. There's even
Uh,
been some studies on this particular, and I never have understood why people call it, I should take the particular out of there, but on work like this to help bring blood pressure down.
mhm.
And the reason that this does that is because neurologically and circulatory wise, when you have movement in the posterior abdominal wall and you have movement in the the retroperitoneal cavity, which is what we're doing with this work,
Yeah.
the kidneys free up and
Hmm.
they're allowed to move. And when their kidneys are allowed to move in the directions and the ways that they're supposed to move and not being pulled and held back because that diaphragm isn't moving in the way that it should, we get healthier responses and blood pressure.
Yeah.
So,
Yeah.
there's so many good things. And then this type of that, concentrating on exhale is one of the best ways to improve heart rate variability in
Yes. Totally.
anybody, no
Yeah.
matter who they are. So
Yeah.
it's like, this is just, to me, clicking all the boxes. I love it.
Yeah. And when you think of breathing, right? This diaphragm, this respiratory diaphragm and pelvic diaphragm, when you inhale, respiratory diaphragm contracts, it flattens out, it kind of descends into the abdomen. So you have negative intrathoracic pressure. The lungs are filling, diaphragm's moving down. You've got negative intrathoracic pressure here, more intra-abdominal pressure from that compression of
Mhm,
those abdominal organs. And that difference in pressure is really crucial for these patients, really for all patients, because that pressure difference matters because there's this reduction in pressure in the right atria. When that happens, you have this compression of the inferior vena cava. And then when that happens, you get this pull of blood back to the right atria, all from diaphragm like
mhm,
moving well. So people talk about the diaphragm like it's great for respiration, it's great for postural stability, but its role in cardiovascular health and in lymphatic function is massive. So for lymphatic return, you need rhythmic stretching of the diaphragm. But if you're not breathing well, you're not getting the rhythmic stretching, you're not getting the compression of the IVC to then get the pull blood back to the heart. So, I mean, the diaphragm is super important in this group.
mhm,
Absolutely. Uh,
100%.
what else? So then if we look at the pelvis, so I always tell my patients, joint position dictates muscle function. So if our joints aren't moving well, if we're locked into these patterns, whether it's at our rib cage or our pelvis, the pelvic floor is the victim in that scenario, right? So you could Kegel or try to do reverse Kegels all you want, but if you don't influence the joint position first, you're never going to get that length tension relationship back.
Mhm,
So one of the things I work on with people is restoring, we call it pelvic neutrality. It's not that you're holding this stacked rib cage upper pelvis, it's that you know how to move fluidly in this alternating reciprocal pattern, right? And there are ways to test that. But basically, here, wait, let me show you a video. I show this to my patients all the time. Sometimes visuals are nice. So, okay. Say someone is stuck in more of an anterior pelvic orientation. So their inlets are more flexed, abducted, externally rotated. Look at what that does to the posterior outlet. It kind of closes down and the posterior pelvic floor musculature gets shorter, okay, and tighter. Everyone that I have ever seen with PVD lives here,
mhm,
okay? it varying degrees, but really lives here with this closed off posterior outlet. So I kind of explain it as like if you had an inflated balloon and you squeezed one side of it, what happens to the other side? It it distends, right? It gets like over lengthened. So the same thing is true for the anterior outlet musculature. So this is what is supporting those vulvar varices. This is what's supporting the bladder. So if this anterior outlet musculature is constantly over lengthened, it has no leverage to support, right? And to pump. So that's effectively taken offline, and we need that to sync up with the respiratory diaphragm. So a lot of my treatments focus on going the other way, opening up the posterior outlet. And when we do that, and we can get that length back into that part of the pelvic floor, then the front half is much more likely to ascend, and kind of this length tension relationship sort of is restored. Then you get that nice pistoning of the respiratory diaphragm with the pelvic diaphragm.
And since bloating and distension are common things seen in chronic constipation,
Mhm.
it also helps them poop better.
Absolutely. Everyone needs that.
Remove the pressure from the poor veins that are already getting, overworked anyway. So
Mhm.
yes, so it's, this is wonderful stuff, and I love the joint position does dictate muscle function, and I also say that how we line ourselves up under gravity is the way it works too. There's nothing wrong with the muscles; they're just not in the position to work well,
Mhm.
or
Yeah.
we're in a position to where they're having to work more
Mhm.
because the
Yes.
priority of the motor system is to keep us from falling onto our nose.
Mhm.
So if we're standing in a certain position, it's because we had to learn that or
Totally.
we're gonna fall over, right? And so, if the joints are really mobile, it's
Mhm.
much more efficient for our motor system to line that body up to where they can lean on ligaments
Yeah.
because
Yeah.
the proprioceptive message that system is getting is, "We gotta just keep them still."
Yes.
That you're
Yeah,
gonna be
and
still here, right? And we don't have to
yeah,
work as hard, and now you can think. So we're win that's our win. Now whether it's good for us or not,
totally,
right,
totally.
it's not but the priority of the nervous system kinda takes over too,
Yes.
so that, if you have to hold this back like this because that's what's being driven by the diaphragm, and that's what's got set up in pregnancy because
Mhm,
we
mhm.
have this ever expanding belly going on, it doesn't just go away when the baby comes out.
Yes, and it doesn't just go away when you fix the anatomical venous abnormality, and
Exactly.
that is why we can totally shine and help these patients. A lot of
Mhm.
people think you do the surgery and it's like one and done, but if you look at the research and you look at the success rates,
Mhm.
68 to 100% success rate. That's a big
That's
range.
ridiculous, yeah.
But none of those people are going for pelvic PT. Pelvic PT
Mhm.
hasn't been shown to be effective for this because they haven't looked at it in this way. So I
Right.
really think that we do have this huge role. It has to be a collaborative effort to really support the patient because, yeah, like those compensatory strategies are still there. And if they're still living in that vigilant state, their body only feels safe in this locked down position. Like there's so much we can do to help.
And it also changes balance. So we
Mhm.
think about this progressing over time,
Yeah.
because we know that pregnant people have a wider base of support. They have to. They will fall
Yeah, they
over
have
if they don't. They have to. But after the baby comes, they don't have to have that anymore. But the system
to.
has lined them up and made it efficient, and now it doesn't know how to change because the
Yeah.
priority is for to take care of this new human.
Mhm. Exactly. Yeah.
Right, and so we'll just keep you in the same posture and position, and we're just gonna go this way.
Yeah.
So there's a lot of competing factors on there. There's balance, there's cardiovascular stuff, there's, respiratory stuff, and there's joint, motion and function and function as well. But I
Yeah.
love the picture here. I love it, and I love the story it tells.
Yeah.
Because
Totally.
I think people respond to stories way better than they respond to a little fact or fiction here or here. But pulling it together in a story, pulling the body together in a story is where we start making the changes.
Mhm.
And we start really looking at those pieces in a much different type of thing. Like, how does this look in vivo?
Mhm.
Like
Yeah.
this living, breathing human versus kind of laying it on the table and thinking this muscle just does this and does this,
Yeah,
It's like, well, not
exactly.
really.
Exactly. Yeah. So yeah, I think pelvic PTs, there are a lot of people who are very well versed in visceral mobilization, and that is awesome. And I think it's like such an amazing tool. But if you have a patient who's presenting with these signs and symptoms, no amount of visceral mobilization is going to fix a refluxing 12 millimeter diameter gonadal vein. Like it's just
Yeah.
not going to happen. Like after the fact, sure, great. We can do so many of those things. We can pull from all different types of paradigms and use all kinds of tools, but it really has to be a joint effort.
Hmm.
So collaborating with vascular doctors and interventional radiologists in your area and taking the time to really learn if they do this work is going to really pay off in the end.
Hmm. And if you live in a place where it doesn't happen, know the place is closer by so you
Mhm.
can the people will go to get the help they need if they
Mhm.
know that this is what it is that they need.
Yes. Yeah.
People will advocate for themselves, they will do things. I know I live in the boonies up here in the at the top of Michigan, close to the Canadian border, and we there's a lot of fundraisers that go on here all the time because all of the children's hospitals and the specialty centers are downstate, deeper into the
Mhm.
mid of Michigan. And,
Mhm.
people find ways. They find
Yeah.
ways to get where they need to go and to do. The biggest thing for us is how do we recognize and start doing the things like you talked about like, does the compression help? Does this help? Does this help? This is
Mhm.
really we've got this element of what's going on here. We have some other elements too, but we've got this element, and this really needs to be imaged, and it really needs to, be treated in the right way to
Mhm.
help that
Yeah.
person get to the part of their journey that they're really looking to get to. It's not
Yeah.
just put compression on and teach them to breathe and hope it all gets better. It's
Exactly.
like, it's
Because it,
like
because
you said,
it,
it's gotta be integrative.
yeah, because it won't. It will progressively kind of worsen over time. That's kind of like the nature of it, especially with additional pregnancies. Yeah.
Great. So everybody watching, we will put in the links to Underworks and Juzo and Emojo shorts so that you have those to kind of
Mhm.
think about and look at. I will also, Julie, see if I can grab a few of your references that you
Yeah.
mentioned so that we can drop the little small bibliography into the show notes as well.
Yeah.
So thank you so
Right.
much for this. This is absolutely amazing information. I can't thank you enough for bringing it and sharing it. Please tell people how they can get in touch with you and
Sure.
tell us about your course because I know you teach this stuff.
I
So
do. This is my third baby is this course. Um, it kind of is a clinical roadmap. So it takes you through where we started with our understanding of PVD and where we are now, how to recognize four major clinical presentations of it, how it manifests across genders. I did some guest spots with Dr. Kathleen Gibson, who was my surgeon and is also
mhm,
the president of the American Vein and Lymphatic Society. She goes through case studies. We go through all of the treatment options and why one person would benefit from one versus another, post-op um, concerns, and how to find and connect with vascular doctors and interventional radiologists in your area. So kind of takes you through the whole process in about 3 hours. And you could learn more about that on my website. It's drjuliebarron.com. And my Instagram is the same. It's just at Dr. Julie Barron. And feel free to DM me. I love talking about this. I could talk about it all day.
wonderful. It's so great. I love the parallels in our work. I
Yeah,
just,
sure.
I love it because I've been talking about the diaphragm and the rib cage and, all of this stuff all the way up to the throat and the neck and how
Yes,
all of this impacts the body and disease states and, these things, to get us out of that regional thinking.
for
And I
sure.
so appreciate your work on this. And we'll drop in. You said you did a podcast or you've done some talks.
Yeah, I've done a talk for Sarah Reardon and Jessica Real for their Pelvic Floor University. I've done a little guest spot for Kathy Wallace for one of her classes. Um, yeah, so I'm trying to get some inroads in so we can reach more people and
Yeah,
really
100%. I'm so
impact.
glad that we have you here and we're presenting this here in the Pelvic Health Explorers because my thing for everybody is to stay curious,
Yes. Yes.
explore outside of the pelvic region, move forward, think a little bit more. You know something's wrong, you know something isn't right. You now have some great resources to respond to. Uh, Julie said she'll be happy to talk with you. She's got a
Mhm.
great course. You can hear her talking on other venues and follow her on Instagram. She'll be telling you where she is and what she's up to.
Yes.
And thank you from the bottom of our hearts for joining us here today and being part of our summer season.
Thank you so much for having me.